not to promote oxytocin, it's not ready for prime time, but studies of it have shown, aha, maybe this is the reason why it's not effective for everybody. Okay, I'm afraid you've had the paradigm shift. I'm such a nerd, right? This slide is really stuff all the professionals here know, but maybe there's some good links in it you can share with your families. There's this article I've saved from the New York Times. It's actually from 2010. It's called Trying Everything and Anything for Autism. And, you know, I'm not going to read the quote to you, but, you know, it's very hard, and maybe it's not even our role, to persuade someone if something's working not to do it. That's not my job. But my job is to make sure what you're doing is not harmful, that there's no long-term consequences, that you understand the risks of what you're doing. Because people can try things like, if you got a lot of arsenic and you got a lot of rice flour in your diet, 5 years from now, I don't know what's going to happen necessarily. So it's important to be informed about the risks of everything you do. The Safari website is a really good one that they have a great newsletter you can share with patients. Spectrum News, another wonderful newsletter, and then all those organizations, of course, produce some really good. I try to get them off Facebook, you know, and occasionally a good link will appear on Facebook. But you know, into looking at the websites and the organizations that do good research, because just because you're published in a journal, it may not be a valid, good peer-reviewed journal. So it's really important. And then I explain to parents what some of these terms mean with randomized design, because they'll come in and they'll be doing something, and I'll say, okay, show me what you're basing this on. And sometimes we go through together what the pitfalls are of the study that they're basing it on. Of course, double-blind, placebo-controlled. Study size matters, and who's funding it. So the hyperbaric oxygen therapy that was so widely promoted and is still promoted by a few physicians in our state. A couple of the gentlemen who published that research also were big equity holders in the companies selling the soft chambers. That's not cool, that's conflict. Andrew Wakefield, same deal, you know, the Mr. No MMR guy. So you have to be careful and aware, because funding does affect research if it's not unbiased. Mindfulness meditation. This is a hot thing. This is showing science. People are excited about it. We have fMRIs, functional MRIs of lungs and scanners showing things are going on in the brain. And there are neurobiological changes that are happening in the brain with meditation. There is an evidence base already for ADHD, anxiety, and depression. It's emerging in autism, and obviously it's starting with that higher functioning group, but probably there's going to be something available for everybody. There is a group called Mindful Kids Miami, which uses the MBSR model from John Kabat-Zinn of UMass Medical School. And there's stuff out there going on in the community. This is not transcendental meditation. This is MBSR, mindfulness-based stress reduction. It's a different form of meditation. There are actual, like I said, biochemical changes that are happening with this, and it's a lot of scientists are getting very excited about it. So it's something worth looking into, and it may be very beneficial to parents. So to parents who live lives of stress, you know, or therapists and clinicians who live lives of stress, this has some really good tools to use. Other areas, of course, hippotherapy, horses, aqua therapy, pet therapy, aromatherapy, that stuff, that's not going to harm anybody, and I'm not trying to dismiss it. Like lavender oil is lovely. Like I take a whiff once in a while and take a deep breath and, you know, go to the next patient. It can be good. But there's that area of some evidence, no harm, which is where I put it, and we have to be mindful of, you know, not everything goes in that basket. And Dr. Scott Jack's going to follow me, and he's going to give you the evidence. But treatments that work, we still know, you know, it's a careful use of meds and supplements and nutrition. That stuff needs to be judiciously used in autism. But exercise, getting kids moving, sleep, reducing stress, making sure kids have leisure activities, getting them outside, off the screen, outside, breathing air, outside. An ABA, speech, OT, PT, the Early Start Denver model, pivotal response training, all of these things. These are the things, you know, these are the bulk. These are the main course. The other stuff is just around the sides. And I try to counsel families, you know, people sometimes travel really far and they spend a lot of resources that maybe they don't have on things that they just, you know, people need guidance so that they're using their resources and time wisely. The rest are my citations. I think I have like maybe 5 minutes, 5-10 minutes for questions. And let's keep them to broad, yes.
Just going back to the melatonin, when it comes to giving kids supplements between the 1 and 10 milligram dosage, is there anything in your experience that would tell you that there's any type of dependence in it, or that you have to kind of alternate, you give it to them for so long and take them off? Or is it something you can give to them consistently?
Like anything, you should give breaks. So we don't have enough data to say, yeah, just take it for the rest of your life.
Okay.
You know, so probably break, but this is where it gets fuzzy, because the guidelines aren't good. I said like an average dose is around 3 milligrams, but like everything, you want to treat it like we use good medical practices with meds and start low. So start on 1 milligram. If somebody's up to 10 milligrams of melatonin and parents come in and they say, we've been doing this for 3 months, I'm like, stop, it's obviously not working. You know, and if the kid's not sleeping. So sometimes people are giving it and they're not seeing the benefit. And they still give it. I'm like, it's not working, so let's stop. It's not effective, you know. But there's no guideline out there to show you 1 week on, 1 week off. The only good study published in the literature was 1 or 2 that showed it can actually delay the onset of puberty. That's yet to be known, and some parents are like, "Ooh, that's great! I want to give it." but unfortunately, we don't have good evidence about how long is too long. But as a general rule, I would say if somebody's on it all the time, at some point you want to take a break. Like maybe it's going to be summer, or maybe it's going to be a weekend, or maybe it's going to be a time when if a child doesn't, you know, sleep is interrupted, it's not going to make everything crash down.
Thank you.
Yes?
Well, I had heard somebody talking about a prebiotic as opposed to a probiotic. Is
Yeah.
there?
And that's a little out of my league. I mean, yeah, there's prebiotics, probiotics. Prebiotics are things like, there's certain foods that are prebiotics, there's one
Something
better
that
than
feed the
another.
good bacteria or something?
Yeah, I don't have enough knowledge, you know, about that to know. Some of those links might be able to help you with that, but. And that does get into the thorny area though, well, which one do you use?
Right.
Right? So once again, we're lacking on guidelines there. So I tend to stick to the good, or the Culturelle and Floristore, or the good old-time probiotic supplements that a lot of the GIs use. But we need guidelines. We need guidelines there for sure.
Medication like Perspirone, do you find that children with autism, that at the beginning you see a lot of benefits and then you have to keep increasing to see that same benefits, or not?
Not really. Like, I mean, I've seen the whole gamut. You know, some kids actually can do well on really low doses. And actually in the clinical trials, we looked at super low, like 0.125. And some psychiatrists would say that's a placebo dose, when it's really not. In kids on the spectrum, a low dose may in fact be effective. But I don't necessarily see tolerance. I see it certainly doesn't work for everybody, you know, and the main thing is dealing with the side effects. And it's also a medication I'm not comfortable with kids staying on long term. Like I really try to get them off. But for some kids, it can be really the difference between being in the community and not. So some kids just need to be on. Yes?
The omega-3 prescription you were talking about, does that come in liquid form?
No. I won't keep it a secret. The one I use is called Viarin. And it's Vayarin. And it's a capsule, and inside it is a powder. So you could dissolve it or sprinkle it. And there is no competition to Viarin yet. I'm sure there will be. Right now there isn't. That's the only one there.
Oh, I have one other, with the fee, for the saliva test you were talking about, through the lab you use, what is the fee?
$300 flat fee. So there's two companies my practice uses, they do the same thing. And for Medicaid, zero copay, nothing, not even that $300 fee. and I don't charge people to collect a specimen, and I don't sell people Viarin. So, listen, profit, it's US of A, right? Go Bernie! No. But I find it's a conflict for me. Like if I'm selling you Viarin and I make $20 on every bottle, it's just not good. Same thing with pharmacy. So I stay away from that, but there are some doctors who don't. So all of these companies, and that's why academics don't like it, but academics need to loosen up a little bit because some of these things can have good promise, So Viarin is not covered by insurance, but it's about $48 a month, so it's not horrible. Yes? Oh, sorry, we got two. I'll get you next. Go ahead.
Is there a way to be able to test for that?
We don't know yet.
Is that something that's prescribed yet?
No, not prescribed at all. Theoretical, research studies, it's been very disappointing so far, but yeah, no, it's in trial.
Getting back to GABA as well, you said it's a waste of money to buy a bottle. Is there another way to get that benefit without buying a bottle?
Really not. But the thing is, we don't know. Is it too much GABA? Is it too little GABA? Is it at the receptor level? Is it at the neurotransmitter level? I know it's very frustrating. I mean, I have a kid on the spectrum too. It's very frustrating. You want to just try stuff because it seems so exciting, but some of that stuff can have more harm than good.
Yeah, I've tried to prescribe things, and he does well on stimulant. He's an A student, and he's not a stimulant, he's an F student, but the stimulant makes him
Right.
check. So he's on and off all types of new behaviors.
Right.
So now he has an DBT therapy.
I'm sure some of your colleagues here they know more about that than me.
Abilify works phenomenal, with the exception of the stimulant wears off, the anger starts, and his gluttonous, eats everything on the planet, I mean, everything.
Yeah.
So the weight gain is so immense that he had to take off of the Abilify, and then we did try to recruit all because of the.
Yeah, it's a chess game. It's tough. Let me just get this one other woman back here who is dying to ask a question.
About the mindfulness meditation.
Yes.
How, is there versions of it that work better with kids who are reluctant to do any type of meditation?
So there's I have some good links on my general website. So there is some stuff that UMass, University of Massachusetts, you can probably find a lot of it there. You have to, so NBSR, there are modified versions of it. Like there's a book called Sitting Still Like a Frog with online meditations, and that's like for preschoolers. Also at the University of Wisconsin, Richard Davidson, like there's people who are modifying it for sure for kids. The Mindful Kids Miami they actually got funding from the Dade County Public Schools. And they are training teachers and ESE teachers in particular. So there's a lot of stuff out there modifying it, but it's made kid-friendly, like through the different visualizations and shortened meditations they do with kids. It's not sitting cross-legged and clearing your mind. It's guided. It's all guided and a lot of imagery. So there's a lot of cool stuff happening there. Yeah. And Mindful Kids Miami has a website as well. Anything else?
Sorry, could you say that again? Mindful Miami?
Oh, Mindful Kids Miami.
Yes, I have a question. How do you know and when do you know that your child should be medicated?
As a parent, you're asking? So that's a great question, and I would say involve your team. So teachers, therapists, and also when your child is stalled, because not every kid needs to be on medication. There are kids on the spectrum who will never ever take a medication, and there's nothing wrong with that. So it's when their level of function is being so impaired in some of the areas that medication can help that it seems logical to try it.
But this is only a dilemma, a problem between the doctors and the teachers. Academically, they will tell you, yes, she needs to be medicated because
Right.
she can't talk. So this is one problem. On the other hand, the doctor says no.
So here's what I would also say is, if it's done safely and conscientiously, a trial is just a trial. So you could debate it all day long, you could get a million opinions, but really you need data and evidence, right, and see what happens. So, but a parent, sometimes a teacher, 1 year, it's that teacher just, you can't get anywhere, and it's that teacher, and you know it's that teacher, and your intuition is it's just this teacher. Don't be bullied into trying medication because a kid can't fit into that teacher's model, you know?
Another question that I have, how long should you wait? Let's say you try a new medication and it doesn't give you the result.
Well, this is what your prescriber should be doing with you in detail. Just as an example, my practice, you start a new medication, we say call the office every week until we tell you not to. Every week. And sometimes we have to chase people down. But yes, you're exactly right, because, and sometimes there's certain medications that take longer to take effect, it may be several weeks. But that's the dialogue that you have to be having with your clinician.
So by an overall month, 2 months, you should be seeing some results?
Well, it depends on the medication. So a typical med follow-up visit in my office is 8 weeks, but some medications will be effective in a week, days to a week. Others, it might be 2 weeks to 6 weeks. Other medications, it might be 3 months on some of the SSRIs. All right, I think we have time for one last question because I think it's Jack's turn. Yes?
One of your slides, you've got a biome?
Biome.
Biome.
Biome, that's just the term for the gut flora. So the internal environment of the GI tract that they're studying and looking at probiotics. And I'm sorry I don't have more specifics on, but that's a hot area of research. I'm not an expert on that. But.
No, thank you.
All right, well, thank you, everyone. It was a pleasure. Thanks.
We're just going to take a few minutes break and then we'll come, people being here, if we can come back about 3 o'clock, we'll have it ready for the discussion.
Yeah, she just gave me I was just trying to tell you, I didn't want to worry about let's see, what was it that she gave me? I took a picture of the phone. Parents as liaisons, PALs. She says they meet on a regular basis.
Oh, yeah.
That's
I've heard of it. I've heard of it.
You've heard of it?
Yeah,
No,
I haven't
she,
heard anything.
no, she just gave us this. And they're called what? PALs, parents as liaisons. Yeah, so that one apparently is.
That's not good. Oh, I would tell her.
Well, there's a website address.
Oh, really? Except for? I'm like, oh my, she's a whole like a mole.
Yeah, I have
And my
definitely
husband's a
whole-
holdout. And like, people, come on. They're just like for my sister. I'm gonna get more on video about this, I swear to God, I think my husband has it. Oh, I wouldn't doubt it. You weren't diagnosed then. Like, I'll be 48. I'm ADHD, I wasn't until I was 23. Was I
Well, and Dan,
diagnosed?
like Dan said,
But I'm also from North Dakota. So what's an off the cuff? You know what? Well, exactly, but there was no diagnosis of any of them.
Yeah.
Nothing. Nothing.
But then again, when you know that, what really can you do? Try the meds, sometimes they work, sometimes they don't. And my thing is enjoy the benefits of the that's why you're young. As you get older, it starts going, and it's like, I used to hold it.
You see, I just laugh about it now. I do a lot of that instead. It just helps me laugh about it. The stuff that I do. But I'll say what I do. You know, so. If you don't like it,
Is yours
no, I understand. Yeah, he's 6. I'm old. I'm old. She has a 6-year-old wife. So she has
What happened is
on the spectrum and one isn't.
no kidding, because it was so hot this morning. I didn't find it hot this morning.
No, not at all hot. Well, but now it is cold, and I'm never ever cold. So it's kind of a big deal.
And I had to be honest, they'll change it, but it will not.
It'll take 20 minutes, an hour, yeah. It takes a long time to change it.
How can they explain that Model 1
Oh, I'm sure it's, oh, no. Those are not identical. Like I have my aunt, my cousin's twins, and they are identical. And one can have kids and one can't. So, like she said, well, donate to the other one, and the other husband won't accept it. Isn't that funny? I mean, I'm like, it is, but that's his, it's not ours. And I'm like, seriously, it's the same exact DNA. But in his mind, it just isn't. Kind of nice. Okay, I don't think it would. I don't know either. Yeah, for me, that'd be. Well, see, I would have discussed that before I got married. I got married late. Like, I got married at 33, so it was a big difference. I discussed everything. How you want to raise them? Because I'm just doing this Catholic. This is not. We're not even going to get married. This is not. Sorry, it's just not hard rock. That. And so then we talked about it. So when we moved here, his parents are Catholic. And they're both very devout Catholic. Yep, they live here. And now that we're here, he's like, we should go to Catholic. They all have. It is not changing yet. I said, we'll be done. Not. Animate. And he's like, okay. You know, and I have nothing against Catholics. But that's not how I wanted the progression of my job to go. I watched that Sunday school. That's my difference. And we discussed it. It was a deal breaker. Like my cousin, she wanted, when she got married, like later than me, like 40, her husband already had children. And he said, I don't want any more kids. And so she got pregnant. They said, this is shocking. But he didn't want to. They split, and they're perfectly fine. Separate. That's a good option. That's whatever you realize now. I've been for years, so I'm available all the other I'm very male. So my husband is a PTA. Well, I think I'm interested in finding some women that are sharp. Because Florida is really behind the time in big time. Almost everything. Oh, what specifically is Danielle's got a waiver. She lost it coming from Virginia to Florida. What's the waiver? What's the waiver? The med waiver. Medicaid waiver. You don't know about it? No. So how you would not know about it? You just have to eye something. That's it. Yeah, what's the name of it? Yeah, my ABA mentioned to me. Okay, you need to know all about that. But there's one of the things is Florida was like this, and then they separated. So you have agencies. Or it had Medicaid. Oh yeah,
saying connect with. You have to have in charge, and I'm asked, so is this a state or is it state reg or is it you have to have in place a waiver support coordinator and a consultant. Waiver support coordinator, you use agencies. Support CDC plus, you get to pick and choose.
Oh, I have to do that.
Yeah. So.
Or they give you a chunk of money and then you divert it
Well,
out.
the chunk of money stays up here.
Right.
Okay, and it has to go through.
Sure, sure.
For your,
But you tell them what you want them to do.
yeah.
Oh, I guess we're on. Look up loans and motion. We need to bring that back. Loan is better than nothing. Loan is nothing.
You can't find providers, and then you can't, in order to be able to use the waivers, in order to use the money, you have to have a coordinator for waiver support in place. How do you do that? That's what I've been talking about. There's no vehicle in place. This one has one for children now, and they've just branched off, I think, into one for, I can't remember what the name of this, but if you go to the planet, this is for children, this is for adults. We need women like you, sharp mind, business mind, to do that.
I mean, I do, but I don't know if you kind of have the whole other piece that I've gotten so forgetful because I didn't go back to work until I was 60. So for 10 years I haven't worked. You know, so you lose your mush.
I know, you look at it, you do that. There's a look at it that also is really sharp. And she has a young child, Downs. She's very sharp.
You know, I have a girlfriend who's in marketing who could probably do that. She, I know her from soccer. You know, and she's brilliant. She says the same about it.
I'm telling you, we need that. There's nobody who don't want it. Thank you. Have a look now. Oh no, oh no. See me use that now in market. Hey man, do you go focus on Martinez? All right.
this panel session. It's good to see so many people that have you stayed around for this. This is great. We're very fortunate to have with us a panel of distinguished mental health practitioners and specialists, and I'm going to let each one of them introduce themselves, and then we'll go ahead with some questions. Noelle, I think, has passed around some cards if you have a question. It is a question. Stories or case presentations would not be quite what we're looking for here. But good, solid questions with this nice question mark at the end of it will be my preference, and the one that I hope to put on the top of the stack. Okay? If we can start here with Dr. Kelderman.
Hello, my name is Dr. Jill Kelderman. I'm a pediatric neuropsychologist and the clinical director at the Center for Pediatric Neuropsychology in Palm Beach Gardens. What we do on the neuropsychology side at our clinic is to do diagnostic evaluations of children. We see a lot of children with autism as well as other types of neurodevelopmental disorders. We see children as young as they come, up into early 20s.
Hi, I'm Cheryl Kirschner. I'm a pediatrician, a developmental pediatrician, and a child psychiatrist, and I work at the same clinic as Dr. Kelderman. I see children from age 2 to 18. I have a lot of experience with kids on the autism spectrum, and also see a range of other neurodevelopmental and psychiatric problems.
Hi. I don't really need a microphone anyway, but it's okay. My name is Dr. Kelly Everson. I'm owner and licensed psychologist of Palm Beach Behavioral Health and Wellness. We're located here in Jupiter. We are proud to be one of the North County partners for FAU CART, so we're running a whole lot of social skills groups for preschool kiddos all the way through, hopefully adults, come this fall. So we run Children's Friendship and Peers. We also have 12 clinicians who work with children, adolescents, and families. I run the autism spectrum clinic there myself, and we are offering therapy, testing services, and recreational services. We're doing video game clubs and hangouts for kids on the autism spectrum as well.
Hi, I'm Jenny Jones. I'm the Clinical Director of Behavioral Services at Helping People Succeed. We serve the 4 counties of the Treasure Coast, and my particular program is children's mental health, ages 5 to 18. We're a nonprofit. We live up to the name. But we have, by default, we've managed to gain experience with children with autism because Medicaid, up until a couple of years ago, was not reimbursing for a primary diagnosis of autism. And yet, because we had a heart for it and the experience for it, we were kind of sneaking them in under the door and providing other primary diagnoses so we could treat children who obviously had co-occurring disorders in addition to ASD. We have social skills groups, we have a transition program, we have several different things that we do for kids with autism spectrum disorders.
I'm Dr. Chris McGinnis. I'm a licensed psychologist. I'm also a board certified behavior analyst, and I work for Boys Town that is 100 years old this year, by the way. Yeah, right. And we're actually one of 11 sites around the country based out of West Palm Beach. And I moved here about 3 to 4 years ago to start a clinic. And it's essentially a primary care outpatient behavioral pediatric clinic. I think I got all of it in there. And we've got 3 clinicians right now, and we've got 3 locations, including West Palm Beach, and then we're also working with Palm Beach Pediatrics, where we're right down the hallway from the pediatricians in Boynton and Waxahachie. That's kind of fun. So I should say that even though I'm a behavior analyst, I'm trained, and I'm also, as far as my daily work, I work with more of a primary care, kind of just most kids out there. If you think of the bell curve, I'm working with about 98% of them, whereas some other mental health folks are working with the tail plus some of the middle of that curve. So that's my focus.
Fantastic. Thank you all for being here today. I started this in 1992, 93, being involved in autism, and it would have been utterly impossible to have assembled a panel like this from Palm Beach County and our Treasure Coast region, with people who are knowledgeable, who are professionally, actively in their practice seeing many children with autism. We simply did not have the services, and it is unbelievable from my perspective, with the benefit of time to look at the changes that have occurred. I can only imagine how it will continue to develop and evolve over time. I think there's some very good things in the future here. The first question I have is, and this obviously comes from a school system person. In the school system, at the elementary level, we get a lot of referrals for evaluations for students with behavior problems. Parents tend to push for ASD instead of EBD, emotional behavior disorder. These children's behaviors are often complex and difficult to tease out what actually is what. Do you have any suggestions to better evaluate EBD versus ASD, or narcissism, sociopathic versus ASD? Anyone interested to take a shot here? Chris? Okay, thank you.
Thank you, yeah.
The others, feel free to jump in.
I'll take the first arrows, right?
Okay.
I'm also my PhD is originally in school psychology, and so I'm kind of looking at this from the standpoint of a school psychologist as well. So let me say, when I heard that question, Jack, I was thinking that first off, you need to know that there's classification, educational classification versus clinical diagnosis. And so that trips people up sometimes. We have to know that there is a difference. The schools can't diagnose, generally can't diagnose. There might be somebody on staff that does, but that's not the rule. And also, as far as EBD versus ASD classification, you have to know that by educational law, that's got to be a decision made by the IEP committee. So that's got to be done there. I don't know if anybody wants to add to that.
I think I would add to that too, that from the school's perspective, as you said, there isn't a formal diagnosis being made, and they tend to look at things in terms of what is impairing the ability to learn, what is interfering with the ability to access the curriculum. And that may or may not correspond directly to what a medical diagnosis might look like, or what type of formulation or conceptualization some of us might put on paper. And it doesn't mean one person is right or one person is wrong. It means there's different environments, so there's different goals that are being there, and it can be really confusing to all of us in terms of trying to tease that apart sometimes.
No easy answer. No easy answer on that, apparently. Yeah. The other part was narcissism, sociopathic versus ASD as well. So.
Can I speak to that?
Oh, please.
I would be pretty concerned about having a child, a school-age child, labeled as narcissistic or sociopathic in the context of versus ASD. I mean, those are personality disorders that usually should not really be diagnosed in childhood. So, I mean, that's just a comment about that. That I would be surprised if that would really come up, and would be concerned if that came up.
Add one more thing to that too. Really, the classification on the IEP is not as important as the goals that are written, and then from there, how those goals are going to be addressed. I don't think the classification is that important as much as it is what the IEP team. Go ahead, please.
I'm a school psychologist, so I'm, kind of listening.
I should give you the mic.
With what you're saying, to some extent, you're 100% right, but in some situations, it gets a little sticky in terms of if you're looking at more of a restricted kind of placement for a child. A program for a child with autism is very different than a child, with ED. So, like a lot of times, what I find is a lot of times in the schools, there's a child who has a lot of behavior problems, and the teachers, the school staff are quick to say, oh, I think this kid's EBD. Then I meet with the kid and I, evaluate the kid and I'm like, no, I think this child has autism. Sometimes you see a lot of the behaviors and emotional kinds of things, as part of it. But it does kind of matter in some sense. But at the end of the day, you're right. I mean, the goals need to address that particular child's
Glad to hear that it matters in this county. Or in that county.
Thank you.
And everybody may not agree with this statement, but just in my personal experience, if you have a child who has a medical diagnosis of ASD, I would highly encourage you to get support around you and to find some other professionals who can come to an IEP meeting with you to advocate. Because I've had the experience of kids with a medical diagnosis of ASD being labeled EBD, and in Palm Beach County, those programs are drastically different. Like, for instance, in this area, you may have a kid who has a medical diagnosis of ASD, but may not, for whatever reason, the school team is not seeing it in school or doesn't feel like they meet criteria. That child could possibly, depending on the situation, end up somewhere like Indian Ridge, versus a child in this area who is better suited for Alamanda Elementary, for example. So if you, my point being is, if there's a concern around that, please make sure you find some support to come with you to your IEP meeting. There's parent advocates, CARD has programs, and many psychologists, including myself and a variety of other people, regularly attend IEP meetings. So I would highly suggest bringing someone along with you to help support that process. Right, the program is PALS as well, and there may be, I don't know if there's brochures around here as well, but there are lots of different resources in this area for that. But please reach out for help if you're in that situation, if that's a question from that.
Did you want me to? No. We have another question. Is a diagnosis important in treating ASD in teens? I think the question may be, is a diagnosis actually important in treating ASD in teens?
A big part of what we do in a neuropsych evaluation is to determine whether or not a diagnosis is relevant or not. And the conversation that we often have with parents is it's not about a label, and it's not about trying to fit a kid into a box. The point of a diagnosis is to help guide treatment. If we have an accurate diagnosis, we can look at the literature, we can look at the research, and have a better appreciation for what usually works for most kids who have this type of a profile. And that is really one of the most primary reasons for the diagnosis. I think it also helps people understand the child better. And there's certainly legal implications in terms of the American with Disabilities Act. There's legal implications in terms of IDEA, which supports educational rights for children with disabilities. And a lot of the teams that I've worked with too have voiced almost like validation that in some ways they feel better knowing, why am I different? Or why are these things harder for me? Or why don't I get that? It I think is important for teens to know that you're not one in a million, you're 1 in 68. This is common. And so to me, it's important on different levels for different reasons.
I would say in terms of the actual treatment process, if you're billing insurance and all that kind of stuff, of course it comes into play there. The actual therapeutic treatment process, a lot of times a diagnosis may or may not even come into play during therapy, during that, the groups, things like peers, obviously work best and are normed on teenagers on the autism spectrum. But if someone is presenting as if they have the characteristics of autism spectrum, they're going to fit well in that group as well. So there's not a criteria that says they must have a diagnosis on there. But I would second what Dr. Calderman was saying, is that there's a big identity development piece there, where I've had kids come to my office that, for whatever reason, maybe just thought like they were the, quote unquote weird kid, and didn't know why, didn't have a reason for that. And I'm not one to have, we don't need a word for it, we don't have to have a label, but that kid who just thinks they're a little different can go a long way to get that label, to be able to look things up on their own, to go on YouTube and find some amazing videos and say, oh, I can identify with this. I think it goes a long way for a kid. So, I mean, you can do it both ways, but not vital in my opinion.
And I've also found in working with parents that most of the time, parents are actually relieved to finally get some validation that yes, in fact, I knew that there was something going on, and my child isn't just weird, and to help them feel that their intuition was right. So as well as I think being empowering for the children, which I think it is, it's also empowering for the parents to be able to know what they need to do to help their child succeed.
Thank you. I found that, let's say you have a child with ADHD, and then you have a child with ADHD and autism spectrum. I found it's very important to have that diagnosis of ASD there as well, at least from a formulation point of view, because not only are you dealing with the ADHD, but you're also dealing with perspective taking and social skills and things like that. So it is important to know what you're treating, especially when it comes to ASD. There are some other diagnoses in psychology and psychiatry that you don't necessarily need to just nail it down. And people can disagree with me, but and again, it might be a function of the population that I treat. But ASD is critical to make sure that, and again, that's different from educational classification because it's all about educational need there, I think. But it's more restricted. But clinically, you want to know what you're treating. And that's very important as far as especially perspective taking.
Apart from treating, is benefits that may be available to someone versus not available to someone, and that can make a big difference. It shouldn't be a critical factor in your decision, in the diagnostic decision, but it can be a practical issue. So it can be a factor there. We have this question: what are the biggest barriers you find to effectively treating anxiety in children and teens with ASD?
For me, and we treat anxiety a lot in our practice, and by the way, our clinic serves generally ages 2 through 18, okay? So, and most kids with anxiety, we usually start seeing them around the age of 3 or 4, all the way up to 17 or 18. The biggest challenge for us, I think, is that we do an awful lot of parent training because we want to train the parents to be the child's therapist 24/7. There's a lot of research support for that, and that's what I've been trained in the most. That's what I love to do, but that requires that the parents follow through with my recommendations, and so that's very difficult, especially when if you have a child with anxiety, you might find that there's a good chance that one of the parents might have anxiety as well. And what we heard this morning, which was wonderful, I thought, is the role of avoidance in anxiety disorders, how avoidance or negative reinforcement in the behavioral paradigm can lock it in. That's operating in the parents as well, by the way. The parent has been avoiding sometimes doing what they need to do in order to get the child over the hill. We need to get the parent to walk the mountain too.
I'm going to agree with that because and I do not want to blame the parents, but in treating anxiety that's co-occurring with ASD, what we see is the avoidant behaviors are definitely getting reinforced at home. The parent doesn't want to send them to school because they don't want to go, they're anxious and they're scared, and the parent also doesn't want to melt down on their hands when they refuse or when they set a limit with the child. So, and a lot of times it ends up with the parent even not being able to bring the child to the office for a session. So we do see a need for the parents to understand that we can't fix their child in isolation, that we can't do this by ourselves. We're wonderful, but I do not, as a matter of fact, have a magic wand at my office. So that we really do need the parents on board to help, particularly with the anxiety behaviors.
In my opinion, I think there's a couple of things, and I think that if you have a child on the spectrum, it's really important to understand where that anxiety comes from, first of all, and to really truly understand what autism spectrum is and why a child diagnosed with autism spectrum disorder views the world as anxious with anxiety because they can't predict the world. And so when we look at it a little bit different and try to put ourselves in their shoes for just a moment, we see it differently. And so when you look at it that way, The things that I would want to even out first before even truly treating the actual anxiety are making sure that there's a behavioral plan in place at home. A pretty structured, here's what I expect of you. If you choose to do this, awesome. Here's all the fun things you're going to get. Here's all the rewards you can have. But if you choose not to, here's what's going to happen. And it gives a child a real structure that they oftentimes have at school and not always at home. Kids love these kind of programs, by the way, because they really are reward-based and they feel like they're winning life, you know, if they're doing it. So you want to make sure that kids are on a pretty structured program at home overall. That in and of itself typically decreases some anxiety because they know what to expect and they can deal with things that kind of come at them on a day-to-day basis a little bit better. The other thing that I would really want to address are sensory issues. If you have a child who is sensory dysregulated, I think that you need to have a solution and work on that before probably addressing some of the other parts of anxiety, in my opinion. So these are things like, you know, the younger kiddos, you might do things like weighted blankets, making sure that they, you know, maybe taking, you know, showers or baths at a certain time of day, or, you know, physical kind of regulation for their body. Similar things for older kids, frankly, but other coping skills, using exercise and movement and all that in order to kind of regulate their bodies first so that we can ask them to manage their anxiety as well. So I think those two things kind of need to come first, in my opinion.
Just to follow up a little bit on what Dr. Evans had said, I think that the hard thing about anxiety with kids with ASD is that the classic therapy for anxiety, CBT, doesn't work that well with kids on the spectrum because they really have a lot of difficulty identifying emotion. And so I think that we have to address it in a different way with the things that Dr. Everson spoke about, which is sometimes more difficult because the learning coping skills don't always work as well. Certainly with younger children on the spectrum. I think a lot of teens, especially high-functioning teens, can learn that, but it's not as easy as with typically developing children.
Next question, okay. Based on your experience, how does childhood trauma, for example, abuse and neglect, impact treatment for ASD? And I have a little statement here to make. About 10 years ago, I was working with a boy from the north part of the county, and he seemed like he really could benefit from counseling, and his parents were resistant. And I got them to relent, and within the context of school, there was some counseling available. And there was an intern counselor, a novice person, and she immediately saw within this child the signs of abuse when we had no evidence whatsoever, and there later were shown to be no evidence whatsoever. But her off-the-cuff view of it was abuse and called it in, thereby creating a mammoth problem for the parents who kind of saw their trust and their willingness to move through with this and allow their child to be counseled was betrayed in a way. That was perhaps 10 or 12 years ago. I would hope that there's a different, I would imagine it is very different now. But these issues of where children do have these kinds of traumatic experiences.
I think I would start off just by saying that the behavioral symptoms of autism spectrum disorder need to be treated before anything else, in my opinion. So you simply, obviously to never negate if there is actual trauma that has happened by any means, but we can't process trauma if we're anxious about the world around us still. So there has to be more structured behavior plans. There's got to be coping skills in whatever form they are, but there has, that child has to feel safe and confident in their day-to-day life before we can start processing, past events, even things, I'm not sure what the question alludes to, but even things like divorce, change of a school. These are things that can be really traumatic for a lot of kids. So it's not just what we typically would think child abuse or other things, but it can be just a big change in a child's life. That stuff has to start with behavioral regulation, sensory regulation, a kid feeling really safe before we can even go there. frankly, you know, I don't want to be a downer, but trauma is a very difficult thing to treat without autism spectrum disorder. You know, when you add a difficulty in processing emotional situations, which is typical, it does make it much harder. It can be done, it absolutely can be done, but that client, that child needs to feel really safe and that they have some control in their life before they're even gonna go in that direction.
Thank you. I have a question from my own interest. Not that many years ago, but some years ago, Risperidol was recommended, and many parents enthusiastically embraced that. And I address this to Dr. Kirschner as a psychiatrist. What do you see as the ultimate fallout from that, and what has, from a treatment follow-up for the boys primarily, where this had been problematic with Risperidol? You see any takeaway messages from that?
So specifically problematic in what way? The physical symptoms?
Physical and perhaps misdirection in treatment, or any ways that was...
Well, I wasn't here earlier, so I didn't hear what Dr. Aronson Ramos spoke about with medication. Having grown up as a pediatrician, I am not the typical psychiatrist who just writes prescriptions. That said, I have found the atypical antipsychotics to be hugely helpful for lots of families. I think that I've seen these medicines change lives in a positive way. You know, I think that kids need to be followed very closely, which I do. Are they benign medicines? Of course not. But I think that the situations in which I use them, kids' lives are so impaired and the families' lives are so impaired that there really is not any other option. So I'm not sure if that answered your question, but you know, I think it can be part of the toolbox in treating ASD. I don't think it should be the first line of treatment, but I also don't believe in totally ignoring that option for certain children.
Thank you. Sleep is a big factor for many parents. It can be disruptive to families, but it also has direct impacts on the child with autism in terms of their well-being, their alertness, just all aspects of their life. Are you seeing this as a factor in your practice, and what kinds of things are you recommending to the family?
So I did some work with Dr. Ferber, who I think a lot of you are probably familiar with, talking about Ferberizing our children. And I think that using the first and foremost sleep hygiene, I think is of utmost importance. Children on the autism spectrum have abnormal sleep architecture, and so I think that in itself creates a lot of difficulties. But if you don't start with the basics of good sleep hygiene, you can't get anywhere. So that I really try to take the time to have parents really go step by step of what their evening looks like. And try to, you know, if I can get them early enough not to establish bad patterns and bad habits. Unfortunately, that doesn't happen a lot. And look, you know, we all need to sleep. So when a child comes into your bed in the middle of the night, the last thing you want to do is get up and bring them back to their bed. You know, and I think that's true for typical kids also. I think that sleep medication, unfortunately, needs to be used sometimes, because I do agree that kids who are not well rested don't do well. But I really try to leave that as a last resort and really try to work on, again, behavioral, I think working with a good behavioral plan as well, and very structured so the child knows what to expect, I think is important.
Can I speak to melatonin?
So melatonin, I don't think the jury is quite out on melatonin. Back 7 years ago when I was working with Dr. Ferber, he felt really comfortable with using melatonin with or without other medications. He saw it, if used correctly, as very safe. I'm not 100% convinced of that. I think it's certainly more benign than other sleep medicines. So I think that if you're at the point where child's not sleeping, family's in crisis, I think that melatonin certainly is a reasonable thing to do. But I don't think we can say 100% sure that it's totally benign.
Yes.
Thank you. Something I find also another angle to this, and I love everything I just heard, something I can add to that is that a lot of parents don't know how much sleep their child needs. And so that's something that I get light bulbs over heads all day long in my clinic. If you have a 4-year, by the way, I use the 2005 guidelines from Ferber as far as the sleep guidelines. And so when I teach this, I teach the 4-10-17 rule that just makes it easier to remember. 4-year-olds need 11 hours of sleep. And some of that can be a nap, usually about 60 to 90 minutes if I recall correctly. And then 10-year-olds need 10 hours. Now, how many people here are parents? Is your child getting enough? No? And usually, yeah, thank you. Yeah, so that's something. Also, as far as relevance for ASD, let me tell you that I think estimates are as high as 85% of kids on the spectrum are sleep deprived chronically. 85%. That's not because of parents, that's because of the neurophysiology there, and so I completely agree with that. Something I would add also about melatonin, something that it doesn't exactly jive with what we heard earlier, and I just wanted to add something. I almost spoke up the last presentation, and that is that melatonin, it takes, I've heard 60 to 90 minutes to actually begin having an effect. Is that about right?
Well, it should be given an hour to an hour and a half before you want to be asleep.
That's it, okay.
Because otherwise, it really messes up the whole sleep cycle.
That's
so,
right.
for instance, if you decide, okay, I'm not going to give my child melatonin tonight, and it's 1 a.m. and they're not sleeping, you can't give melatonin at 1 a.m. So, I tell parents that if you're going to use melatonin, you use melatonin. And if bedtime is 9 o'clock, you give it at 7:30. And I think that's an important point. That's giving it at the wrong time is probably the biggest danger of using melatonin.
So if melatonin does not seem to be working, give it earlier and try that. That's something I like.
And I would just add, for the frosting on the cake, from a brain behavior perspective, probably one of the best things you can do for good cognitive functioning is sleep. There is a plethora of research outlining the negative impact of sleep deprivation on attention and focus and processing speed and working memory and everything that a kiddo needs to get by during the day. Irritability, frustration tolerance, and if we think about how many kids on the spectrum are sleep deprived, and then we look at their cognitive functioning and behavior regulation, this is key. It's fundamental. And it's important for typical kids too. And it's well established a lot of kids with sleep apnea are incorrectly diagnosed with ADHD. We treat the sleep apnea, guess what? They don't have ADHD anymore. They were just tired. So it really, really is important.
Just a quick pearl. Kids do not snore. So if that is a sign of upper airway obstruction and possible sleep apnea. So if you have a child who snores, they need to be seen by an ear, nose, and throat doctor, or they need to have a sleep study. Because it's, and I'm not talking about noisy breathing. I mean, I'm talking about true snoring is a danger sign. No.
I was joking, I said, can you give us an example?
Well, here we have a question that may prompt some responses. Any opinions on therapy animals? For example, service dogs for ASD.
We both have one.
There you go. Well, this is the federal laws are very permissive in this regard in terms of schools and in other settings for service dogs, including in educational settings. And I know for seizure dogs, they're dogs that are specially trained or especially talented in that regard. They can be truly life-saving for someone who can, yes. So, somebody want to?
Well, just anecdotally, I mean, this isn't scientific at all, but I have a 3-year-old Labradoodle that I've trained as a therapy dog, and he comes to work with me, much to Dr. Kelderman's chagrin. But I will say, I mean, everybody loves him, but my kids on the spectrum, it is amazing what Augie does for them. I mean, just amazing. The anxiety level goes down, the interaction improves. I mean, it really is remarkable. And I think you can speak the same.
Absolutely. We have a therapy dog at our practice. He's my personal dog as well. We went through lots of training to do that. And he comes about 3 days a week with me to my practice. And I've chosen specific clients typically to work with him. He doesn't work with everybody. But what I would say absolutely, and it literally gives me goosebumps thinking about it, is I have certain clients that first of all, wouldn't have stepped foot in my office if he wasn't there, probably, and probably still would not come back if he wasn't in the room. But because they love him so much, and because therapy for a child on the autism spectrum, for certain kids, is very threatening as it is. We make it as fun and less stressful as possible, but the thought of sitting on a couch or something and looking at someone and talking to them, and that's the idea of therapy and what some of it really looks like, is really threatening to a lot of kiddos especially. And so for those of them that are sensory seeking especially, something like having an animal that they can sit and touch the hair of while they're talking makes all the difference in the world. The other thing I would say is that certain kiddos need to learn intensity of touch, and they need to learn feelings and what those look like. And I've used my dog to teach kids when his tail goes under, when they've touched him too much, or when they've gotten too loud, or when they jump up and they can watch his tail go down, or they can see him come by me instead of coming by them. Or a look on his face, and we look at the feelings chart then too, and we say, what feeling do you think he's feeling? And instead of saying, what feeling are you feeling right now, putting that on an animal that they love already can make all the difference in the world. And so there's things like that you can use. Not only are they just a comfort in the room, but you can actually help teach kids that. I've had multiple kids who are, I think the question actually alluded to also the use of therapy dogs, getting a dog for a child on the autism spectrum, and I've had multiple kiddos go in that direction after this experience, and we've worked before they got a puppy or before they got the dog in teaching them things like intensity of touch. How do you pick up a dog so they're still comfortable with you? Now, most kids, that's probably nothing to do with autism spectrum, but most kids wouldn't really know how to do that, and the dog would be flailing around and stuff. But to teach a child on the autism spectrum how to touch so that the dog doesn't run away, using a trained therapy animal is amazing because he doesn't run away. He allows them to do that kind of thing, and it can be hugely beneficial for them at their house. I do have children that I would not recommend a therapy dog at home, and those are kids that are severely behaviorally dysregulated still. And so, because you don't want to put a dog in a situation, or any therapy animal in a situation where the kid is still really dysregulated and might be hitting mom and dad, or is still might be physical, because it's really hard to come back from if they've done something to an animal to get that back. So I would highlight, I have a couple of kids that work with Bentley in my office, without having a dog at home, and that's very purposeful because of that. So for me, that would be the main exclusionary criteria for that, is to, if they're still really dysregulated, you're probably not going to want to go in that direction.
Moving to a tough question, but one that I see increasingly out there, where it often gets teens, young adults in trouble, and that's an interest or preoccupation with pornography. or inappropriate sexual actions, sending messages to what could be a peer, same age, or perhaps a minor that could get them in trouble, or touching. Some of this being trouble that is not easy for them to get out of. I saw Dr. Helderman in a hearing 2 days ago where a young man was in massive trouble because of factors related to his autism, but related to violating the societal norms. And it just became a massive mess. And I was so impressed with your testimony, your ability to recall details and to just pull it all together for the judge who was there. But this is an unfortunate thing when we have to do that kind of testimony because someone has gotten in trouble that perhaps teachers and parents and therapists together can help prevent in I'd like to think most cases. Comments on this?
I think we're seeing this increasingly. I would hypothesize partially because of the internet, because there's access, and it's easy access for children of all ages at this point in time. It is difficult, and from an assessment perspective, what we need to determine is this pathological? Is this a sexual deviation? Is this an intense interest like we often see in autism? It just happens to be with a really inappropriate topic. Or is this related more to trauma or abuse, or just kind of a typical adolescent who's exploring sexuality that doesn't understand the rules on how to do that? And that's tricky for any adolescent, let alone, if you struggle to kind of understand the basic rules and the basic social world, understanding dating and sex is a whole nother level. Some adults haven't figured that out, let's be honest. So it really is a complex situation, and in the case that you mentioned, it also brings what is unfortunately a relevant topic about how kids on the spectrum interact with law enforcement and what's happening there. And maybe we can circle back around to that too, because I think we're increasingly seeing some concerns there. So my perspective is to first kind of determine where does the behavior come from. And what's driving it, and is it something more serious in terms of a deviation, or is it kind of another quirk here that we're seeing that we want to target that way?
I would just add, I think in terms of treatment, it's really important, first of all, for kids who are entering puberty and beyond to just understand the very basic boundaries and social rules that are related to that. Whether that's done individually or it's also done really well in the peers program, so if they're in a social skills group. But I also think that it needs to happen one-on-one, a parent or a trusted therapist. But you need to talk about things like when a child first starts masturbating, for example. We need to teach children where is it appropriate, when is it appropriate, that it's not bad, but here's the limits on it. Here's exactly what can make this okay. And I think it's having open conversations, starting in a place like that then produces children and adolescents that know some boundaries on that. Then we go into things like the peers program teaches that are basic social skills in terms of how much do I interact with people? What if I have a crush on somebody? Can I send her 50 text messages and tell her all about how much I love her and all those things? No, there's a 2-message rule that we talk about in peers. So we go back to these social skills, and we can always revert back to these things, and we can use those basic things, and they're very structured social skills to help kids, especially kids on the spectrum, but frankly, all kids should be in peers, in my opinion. But all kids should be taught these kind of things. But it's just having healthy boundaries of what's appropriate, what's not. Then the other part of it is parents educating themselves on parental limits, on different media as well. My biggest recommendation for parents is to actually go into the store, the AT&T, the Verizon, the Sprint store. They do not advertise their parental controls online because they don't want kids to know exactly what they are. If you go into the actual store, there are a copious amount of different parental controls that you have access to work on your child's devices as well. So not only teaching them the boundaries, but then actually placing those boundaries on there, because you're right. I have kids, this is a conversation I would say almost weekly in my office, where kids send a picture because very innocently, I liked her. That's all it is. I like her. the picture, you know, is inappropriate, but he's heard that that's what's normal, like that's what's going on. And frankly, unfortunately, it almost is, which is sad, but that is, like, there is a lot of that going on. But I sent it to a girl that I've never spoken to before at all, but I just wanted her to know I liked her. So now you've disseminated child pornography, really, and kids we have teens on the spectrum all around who are being charged with dissemination of child pornography at that point, because then what happens if somebody else gets it, and then somebody else gets it, and somebody else gets it? So that's why I think those boundaries in the beginning are so important, to be able to, you know, to know what your child is doing.
Can I say, add one thing? We were talking about ASD versus EBD as far as the IEP classification. Oh my gosh, this is, I didn't even think about this. This is a really good reason to make sure that if a child is on the spectrum, that the school knows. Because these kinds of events are looked at differently, yeah, exactly, because it's a skill deficit more so than anything else. The child needs to be taught rather than to be punished.
Did you have a follow-up question for that? Yes.
When you say in terms of sexual orientation, at what age should we be talking about this important? It's very challenging as a parent.
Sure.
And you say we, you mean professionals or the parent itself? That's very difficult and challenging.
Yeah. So every family is totally different. If you have that relationship with your child, then it absolutely should be you and can be you. If you have a trusted professional in your child's life, it might be them. On a daily, I would say on an almost daily basis at this point, because I do see mostly adolescents and young adults, I have conversations about gender identity and sexual orientation in adolescents especially. So I have some middle schoolers that will come out and we'll talk about questioning. In this generation especially, we do want to kind of normalize it to a large degree, because there's a big part of identity development in adolescence that is happening, and they are questioning, you know, where do I fit in? What if I'm not the typical boy? I don't look like the typical boy, and I don't feel like the typical boy, but I also don't identify as a girl. And, you know, they're having these thoughts, and, you know, where do they fit in is really the core of that. Same thing with sexual orientation. That can be a fantastic question and an area to open up a whole lot of, you know, amazing next conversations with children and adolescents. You know, sometimes you see younger kids bring up, you know, thoughts about that, and we just want to kind of look at that and make sure that there's no other, you know, other situations that are adding into that. But it would be very developmentally appropriate, I would say, for your middle schoolers and your high schoolers to start having some of those conversations. Not all of them, but it's pretty common, you know, for them to be talking about that.
Let me move to this other question, and we'll get yours. Do you have thoughts about the autism GI connection, gastrointestinal connection? There's parent enthusiasm on this from time to time. Dr. Gershon, do you want to comment as an MD?
So my feeling about it is I don't think you can make a generalization. I truly believe there are some children that I've taken care of on the spectrum where there is a clear gut relationship. There are some where it's not. So, you know, I'm certainly open to discussing that with parents. I think that I'm open really to any alternative treatments as long as they're not harmful. And so I never say never, but I never say always either. I don't know if that answers the question, but.
How do you know if you know, I mean, other than, you know.
So that's the, right. I mean, that's the problem. I mean, I think that what happens is parents will do a gluten-free, casein-free diet. They really feel like their child gets significantly better. They then introduce it again and the child does worse. Is that proof? Well, I guess that's about no, probably not, but practically speaking, it is. And so things like probiotics, I mean, they're benign. So why not? You know, I think the only thing that I feel about any restrictive diet is for so many kids on the spectrum, food is such an issue that I really struggle sometimes advising parents to do a restrictive diet, because then you're really restricting a child who already has restriction, and then you've got another whole area of conflict. So, you know, that's why, do I think it can be helpful? Yes, I think it can be helpful. I think it needs to be done individually. And, you know, really what's best for that family.
I just wanted to add really quick, and I don't mean to be a broken record about this, but there is a sensory component to this as well. And so, in my opinion, it's really important to make sure that kids are regulated sensory-wise when you're looking at this as well, because eating and elimination is a sensory experience for a child. And so it's not, you know, what they take in kind of, you know, makes that problem, but there's a sensory piece to that. You know, there's a sensory piece to why a lot of kids on the spectrum eat chicken nuggets and McDonald's French fries. There's a sensory piece to that. There's probably also other chemicals and all kinds of other stuff, but there is a sensory piece as well. And so you do want to make sure that you have some stuff in place that kids are better regulated sensory, in addition to all the other things that you're trying for their diet and life and health. And right, exactly.
Can I say something to that? Chicken nuggets is, my son is having behavior issues right now. I just got a text that he had another episode today. And so anyway, so what I'm saying is, his chicken nuggets, and everybody's been saying chicken nuggets so bad for him, which it probably is, okay? But, you know, if you take away the chicken nuggets, it's like behavior time. So you have to weigh it, I guess.
Personally, I mean, I don't want to answer it from a medical perspective or anything. If you eat one thing and only one thing, it's never good. But from a behavioral perspective, the first thing that I would target actually is rewarding him in small increments when he'll try something else. So you want to hit it from the other end first. So, you know, so great, you know, like he's going to still eat chicken nuggets for a little while for most of his meals, but if he'll start trying a few other things, my question to parents on any behavioral stuff is figure out what your child's currency is. So adults' currency is money. We run by a society of money, but children's currency is not money across the board. It's usually electronics, but it sometimes is other things. So figure out what your child's currency is, and then start rewarding in small increments. If he'll even, I mean, I had one kid who was just putting something on his tongue and not eating it, and that was the first step to it. So we rewarded that. Great, you tried something else. Then if they ate one bite, you know, so what you're really focusing on is adding in a reward instead of punishing the, you know, the opposite.
Chris wanted to weigh in.
Picky eating is something that we do in our clinic. We work with that, albeit not with moderate to severe autism. But there's a book that I'd like to recommend to you. It's written for clinicians primarily, but I find that it's written for really a general audience. It's by Williams and Fox, 2 X's. Williams and Fox, or Fox and Williams, I think it's Williams and Fox, Treating Feeding Problems. And it's a spiral-bound book. It's a paperback. You can get it on Amazon for probably, I think probably $15. But that has an awful lot of information there that you could look at. You could even, if you can find a therapist, especially a seasoned behavior analyst who knows about that work. There are feeding clinics, inpatient and outpatient, around the country that base everything they do on that content.
And in addition to your efforts down there at Boys Town, for a child who may be more severe, the program at Nova, the recent program at Nova, is coming off that same body of work. And so, and we have presentations upcoming from their key staff. We had a question over here, please.
Actually, a comment and a question, kind of cycling back around to what we were talking about with some of the inappropriate, behaviors and stuff. My brother is a CHP, and he tells me stories, crazy stories all the time. Of course, he has all kinds of interesting things that he experiences. But he told me recently of I think a 16-year-old boy out there in California who ran out into the middle of the highway, the interstate. interesting day was to try to get this naked guy in the back of this cop car. The point of my story is his attitude about it was when they got him to the police station, his mom came and said, my son has autism. And a lot of the people standing around kind of said, well, I don't really care if he has autism or not. He was naked in the middle of the highway. Yeah. So I kind of, you know, on that note, I hope that, you know, as we sit around, there's some of those people sitting around talking about it too. And I don't know if there is, but, you know.
Let me help with that. There's an Arabic proverb, it's best to be fully clothed when dealing with a naked madman. I think if you're a police officer, best to be fully clothed with both your officialness of your uniform, but knowledge of autism and sensitivity there. We have a legislative act in 2016, the Wes Kleinert Act, and this leads me into this question we had here. And this act in the Florida legislature says that if the police are questioning a person with autism, either as a suspect in a crime or as a witness, that the person can request that an autism professional be present before the questioning commences. It doesn't say that the police have to pay for it, or, and it doesn't throw any statements out of court if they, you know, in the way that a request for an attorney might. But here it would seem that prearrangement would be the ticket between the family and the therapist or the individual. Are you having any? Is this having any impact? And I guess the broader question may be, when a person with autism is talking to the police, do you provide any advice for them?
I think the answer is twofold. I think one is we need to try to fix the problem and educate law enforcement officers, and that's easier said than done. I mean, there's still a lot of need for training in basic, basic mental health issues.
June 13th in Port St. Lucie for law enforcement. Did one last summer. Yes.
And it's a lot. It's a lot to expect law enforcement officers to understand, but I think that's part of the answer to the question. I think, you know, I had a conversation with a family the other day who were wondering about whether or not it was time to share the diagnosis with their 10-year-old son. And we were talking about the different reasons why that might be beneficial. And one of the reasons is, you know, it's probably a good idea for us to teach children, if you're talking with a police officer, to say, I have autism. And hopefully that will instill some, you know, alter the behavior of the officer to kind of approach it maybe in a different situation, or to pull in somebody who can provide the expertise that's probably relevant to that situation.
For your own records, and if the parents in the room aren't aware of this, if your child on the autism spectrum is ever in a legal situation and police are called, I would recommend that you have in your head and you try to get them to remember that at the very least they should ask for a CIT officer. That's a crisis intervention trained professional. And most of the sheriff's department have been trained, and some of the local police officers have been trained. So at the very least, that would be something that you would want to request in that situation. If you can, I know that's in a crisis and stuff, but if that can come up, you want to request a CIT officer. And if they have one trained on their force, it is mandatory that they get that person.
One question over here, and then I think for time, we're going to get a very brief statement from each of our panelists. Ma'am?
I was going to say that there's something called a wallet card for people that are nonverbal or people that have a hard time speaking when they're in a stressful situation. And it's on justdigit, I think it is, .org. And it's a free service. I have one, I have autism too. And I have one in my wallet. And whenever I see a policeman, if they're coming toward me for any reason, the first thing I do is hand them my card, and then they understand what to do. It says it's specific instructions on the card, how to speak with me, how to do things. They have my parents' phone numbers on them. So no matter what happens, at least there's availability in that way. Yeah.
And this can be added to a person's driver's license. This is a mixed blessing. a D gets put on the driver's license if you have one, indicating disability, which from a disability standpoint is a little bit of an odd thing. But if you have a minor child or a child who's not going to, they're not going to be a driver, you can get them an identity card as part of this West Kleinert Act for $1 with the motor vehicle.
Talking as a professional and as a partner, we're talking about police department and that kind of stuff. It's a huge problem. But we have another problem. I know we are in Palm County that school district is pretty good, but we in the school district have a lot of issues with people who's working with our kids and they don't have any idea about what they are doing.
Right.
I have people who just been in a family reunion, they said, well, I'm working with this school, and in the aftercare program, I'm taking care of kids that are in the spectrum, but I don't know what I need to do with them. I don't know how to teach the other peers how to behave with them. And also we have a school district calling parents or calling the police department because one of the child is doing something that is not appropriate. And also we have a school district who is not taking care of the other diagnosis of the child has. And we stay all day talking about comorbidities, and most of our child has something else. And when you are reading the IEP or when you are talking in the IEP meeting, they just talk about the spectrum. They don't say anything about anxiety, about ADHD. They don't give you a correlation. What is your position about it?
In terms of aftercare, we have a major organization in the county called Prime Time that's funded primarily through Children's Services Council, which we pay tax money to. Children's Services gives out about $120 million per year, and they give several million to Prime Time. Prime Time, though, has a staff larger than our card staff. They have no people with disability expertise on there, no disability specialists, which continues to amaze me. This will continue as long as the citizen taxpayers continue to be comfortable with it. They advise all of the after-school programs and provide the expertise that is needed for after-school programs. As long as people are comfortable with that, it will continue. There's been a marginalization of of persons with disabilities, largely through our Children's Services Council. This is partially being remedied, but also through Prime Time. So I'd urge you to direct there. I know there are a lot of concerns about the school district, but Palm Beach especially is one of the most progressive in terms of limiting the use of restraint and eliminating seclusion for all practical purposes. And the teachers, we'll see 150 teachers, most of them from Palm Beach and our other counties, at our teacher days here at the end of July. So there's still much to be done, and we could spend a lot of time on that. If we get one comment, yes.
I just wanted to speak to, so in Palm Beach County, the principals of each school dictates the education that staff receives for the most part. That's how it typically works. So if you're in the schools, I would, and seeing a problem and looking at that, I would highly recommend that you really petition the principal of that school as your first step, because there are agencies, CART included, clinicians. A couple of things that a lot of psychologists in the area are doing are, first of all, school observations. So coming in and just watching a kiddo to find out what things in the area, what things in the classroom are really not working for them. We do aftercare observations all the time in order to give recommendations to teachers and staff. But then the education piece, I think, is really important. And so if you can petition to that principal overall to ask for certain education, they can bring in, professionals, they can bring in agencies like CARD, they can, if they're open to it, to educate them on what does it, how to identify a child who's having a behavioral, issue, who is on the spectrum, and what else could they look for, how to handle that. So I would encourage you to kind of like Jack is saying, make a little noise about that and try to, I think get some education, because we need to I agree with you. It's Palm Beach County in the grand scheme of things is amazing in terms of what they do, but there's so much more education that needs to happen.
Could we make a brief wrap-up comment, and we need to end in a few minutes. Chris, if you would start, do you want to follow up on that last?
Yeah, let me follow up with that, and then I'll launch right. Okay. Let me add to that. Let me tell you, as I was listening to that, I was thinking, my gosh, if I've been doing this 20 years, and I primarily worked with children and families, not so much adults. And so I come into contact with educational issues and what's happening in schools. If I had one wish that would impact something having to do with the families coming to see me, I would want every single school person, from the principal down to the janitor and everyone else, lunch ladies, I want everybody to be a behavior analyst. I want everybody to be trained behavior analytically. They don't have to have credentials, but I want them to know what they're doing in terms of how to teach and prompt and reinforce and place other things on extinction and hold that constant. That's what I love. Okay. Thank you. And that would solve that problem. But I will add one more thing about that, and that is that if the principal doesn't know that it's an issue, then it won't happen. And so I would say you have to tell the principal, and just it's all about training. That's all it is. Okay. As far as my closing statement, Jack, thanks for inviting me. This is an honor to be up here with all these folks here. So thank you. And it's an honor to be here in front of everybody. Thanks for attending today. This is cool. What can I add to that besides thanks a lot?
I also glad to see all of you all. I enjoyed participating throughout the day. The one thing that I've learned about working with kids on the spectrum that has helped me the most, and I supervise the therapists who work with them, came from Tim Kowalski. Now, this was when we used the word Asperger's, which of course we can't use now because it's no longer in the DSM-5. But he said, you've got to put on your Asper glasses when you're working with a kid on the spectrum. You've got to put them on and see things from their perspective, because they can't see it from your perspective. And so that really has been helpful for me, both with family members and with clients and with the therapists that I supervise. Thank you all for coming.
I really don't need two microphones. The one is plenty, really. Thank you for inviting me today. And the thing that I would say is that I know there's a lot of parents in the room, and the thing that I would want to convey to you today is don't give up. There's hope out there, and a lot of times what we see in our practice is we see, I get a lot of adolescents that have either been through multiple treatment options or haven't been through a lead treatment or whatever, the mixture of it may be, that are really struggling socially and have withdrawn or isolated or are playing video games for 10 hours a day and not interacting with the world. And I would say to you, I've seen complete miracles, and I've seen kids who didn't want to be in social skills group try and go into a lunchroom and try to interact with some new kiddos and put effort in there. And so there's always something that we can do. And sometimes if you needed a new set of eyes or taking it in a different direction can be the saving grace sometimes in that. And there is always something that can be modified or done in a school setting. So so many parents, I know the problem is there's such a problem in school, and there is help out there for that. So keep asking for it.
So, and I'm honored to be here. As the only medical person up here, I just would like to share that I've been taking care of kids, aside from my own, for over 30 years. And when I first became a pediatrician, I can remember one child in my practice that I think was on the spectrum. Did I miss some? Probably, but not that many. And now in my practice, I see at least one new child a week. I would urge those of you who are parents that if you are concerned about your child, I would go with your gut and have them evaluated, no matter what other people are telling you. It's amazing the kids that I'm seeing in middle school and even high school who are being diagnosed for the first time, which just, it blows me away. So, you know, I would urge you either a medical evaluation, a neuropsychological evaluation, a psychological evaluation. I know many parents are scared of psychiatrists. You know, I get that, but we don't all just write prescriptions. But the main thing is the earlier we can identify kids, the more successful they're going to be. So thanks for being here.
I agree. I'm sure we have all had mother after mother, usually mother, but dads too, say, my gut, I knew it, there was something different. And everybody told me, don't worry, he's a boy, I'll give it 6 more months. And, you know, kind of blew them off, essentially. I don't think I've ever told a mom, no, you're wrong, everything's A-okay. Which, you know, is reflective of the population and the services that we provide. But you know, we're very lucky to have FAU Card in our community. I think it does such a nice job of kind of pulling all of the different resources available together. So thank you. And thank you for having us here.
Well, thank you for being here. Your time is very valuable. Thank you for volunteering to show up here. Those of you who are part of the mental health community, please spread the word that there is an important role for what mental health professionals can do in relation to persons with autism, not just children, but throughout the lifespan. If you're a parent and you're not registered with CARD, your family's not registered, please do. We can help you, I'm almost certain. If you're a professional and you haven't signed up for our newsletter and other information, please do. We have a lot of good things coming up. They're almost all free. Dr. McGinnis will be doing a special session on sleep, and we have others coming up on a broad array of topics. It looks like, based on the enthusiasm we saw for this, that we will do this again next year, most likely during this same time slot. So if you have suggestions for that, share it with our CARD staff. And with that, I will thank you all for being here and wish you the very best of luck. Can we give a round of applause to our panelists?
Thank you so much, Amy. Nice meeting you.